Welcome, everybody. We're just going to take a minute or two to settle in. We've had a couple technical difficulties, but we've managed to overcome them, which is always a good thing. Just in case you're making sure you're in the right place, this is welcome a doc talk. Do we have a deck, Manny, that we're going to put up, or do we have a? Maybe start with that, just so folks know it's there. Atypical learning: how to support complex kids. This is there's a sort of a subtitle on this one: caring for neurodiverse children and youth and understanding your child's behavior. A conversation about recognizing atypical behavior and how to seek assessment and supports. My name is Jeff Malmgren. I work with the Burnaby Primary Care Networks, and I'll be sort of hosting this conversation. Really excited to have this conversation today. I do want to say that this is our first DocTalks that we've done in partnership with Curiko, so that's made it that much more exciting. Really welcome this partnership and look forward to continuing it as we go forward. A couple things. If you would like to share this Doc Talk afterwards, it is being recorded and it will be available in perpetuity on the burnabypcn.ca website. So the link should go up. I can't promise it will be there by tomorrow, but it should be up relatively soon, and you'll be able to share it at that time. In terms of questions, I sure hope you have some questions as you go through this. I think you'll find that the presentations are particularly compelling, and your questions are welcome. But what we'd like you to do is put your questions in the chat or in the question piece. Either one works, we'll get them. We won't have questions after each presentation, but we will do some questions and a roundtable right at the end. And we're leaving lots of time for that. So please make sure that you do, if something comes to mind, don't worry about whether it might be answered later. Just throw it in the chat and we'll make sure that we get to it. We have a great panel with us today. We've got Dr. Robin Friedlander, who was with the Department of Psychiatry at UBC. He was a clinical professor. He's a clinical professor there. We have Rachel Godden from the Burnaby Association of Community Inclusion. We have Michelle Long from Community Living BC, and we have Nicole McPherson, who is the District Vice Principal of Inclusive Education for the Burnaby School District. So you can see we've got some great voices. And without further ado, I'm going to let you stop listening to mine. I'm going to pass it over to Dr. Friedlander, and we'll come back and talk to you in a few minutes. Thank you.
Hello, thank you, Jeff. Can everybody hear me okay? Okay, good. Yeah, so thanks for very much for asking me to join this panel, and I just got a couple of slides just to kick things off. So can I have the next slide, please? So I just want to let you know who I am. So I'm a child psychiatrist, although actually I worked with adults my whole life as well. And the neurodiverse population that I treat at BC Children's Hospital in our neuropsychiatry clinic are children and youth with autism or intellectual disability, often both. Okay, next. And how do they present? So these youth, or children and youth, they present typically with aggression to others, self-injury, so hurting themselves, sleep problems, running away, and not listening to adults with adult requests, which we call oppositional defiance. So they present with behavior problems as a rule. Next slide. Oh, so there should be one more. Okay, let's go back. Oh, there we are. Thank you. Yeah. And you can see that there's a very high rate of psychiatric or mental health comorbidity in this population. So, for example, about half of these kids have ADHD, which is about at least 5 times the rate in the normal population. Anxiety, about half. Probably, I mean, the normal rate of anxiety is probably around, in the general population in children of clinical anxiety, is probably in the range of, 15%. Bipolar, 14%. I mean, the rate in the general population is 3%. Depression, 20%. Um, that's not, I mean, the lifetime risk of clinical depression is about 20%, and OCD 12%, which is, the normal rate in the general population is 2%. So you can see much higher rates of comorbid mental health conditions. And that's pretty much how I make a living, is by seeing kids with aggression, seeing what psychiatric disorders may be driving their aggression, and treating it. Next. Take that slide out. So just keep going. There's a last slide on Compass. Yeah. So I just want to, no, hang on. That one. Thank you. Yeah. So I just want to let you know that I also work for a service called Compass, which is basically a consultation service for physicians and nurse practitioners across the province. And basically there's a recognition there'll never be enough child psychiatrists for the province, ever. And so Compass is a program through BC Children's Hospital that attempts to provide consultation for primary care physicians on any kids they have with complexity that are out of their comfort zone, and we're happy to discuss the case and give advice. So that's pretty much all I have to say.
So thank you, Dr. Friedlander. And I didn't get a chance to give you a more fulsome introduction, but I think you alluded to it. You worked with at Children's Hospital in neuropsychiatry, and as well as at UBC and are, as you say, this is where you live. This is the world that you're living in. I have a question just before we move on. I mean, you talked about the comorbidity of do you often find that folks kids come in through your door with one thing, and it's really a conversation about something else by the time you sit down with them?
Yes, I mean, and I'll tell you what happens is that, as you probably know, there's a big pull for families with complex kids to get an autism diagnosis. And what's happened is the autism sort of diagnosis has broadened. So a lot of kids who've got more mild autistic features are getting an autism diagnosis. And the families come in and understandably assume that the child's behavior problems are due to autism. And it may well be due to one of these concurrent mental health conditions, which we can treat.
That's really interesting. I mean, yeah, and I think that, to me, when we started talking about this session, that was the kind of thing, whereas there's so many things that are kind of the potentials for parents. That's where it really gets challenging and confusing, I think. I would imagine. So you spend a fair amount of time not only talking to kids but talking to parents.
Well, so I can tell you in my practice, I'd say that half the kids I see, more than half, have minimal verbal skills. And so the primary clinical assessment and management is via the family.
Yeah. That's an interesting place for parents to be, isn't it? Trying to be that translator.
Well, yes. And I think I think what's also interesting is that families end up becoming de facto case managers of their children, which is not something they signed up for.
Nor were necessarily trained for.
Correct.
Yeah, that's thank you. We're going to have more of this conversation. I really appreciate this, and when we come back, I hope that folks are thinking about the questions they may have. When we come back with our panel discussion, there'll be plenty of opportunity to talk more with Dr. Friedlander. I will take a little time to introduce Michelle Lung. Michelle is a registered social worker with the BC College of Social Workers. She's a quality service analyst for CLBC, and she's been with CLBC for quite a long time, almost 7 years. She's been both a local facilitator and, particularly important to this conversation, she's been the eligibility facilitator for the South Fraser region. I think Dr. Friedlander kind of alluded to that in some of the eligibility pieces, and I know that it's a really pertinent conversation and stuff that is a growing growing interest and concern as the sort of that we talk about that spectrum, that broadening of the autism spectrum. So I will turn it over to Michelle.
Thanks, Jeff. Hi, everyone. Yeah, as Jeff mentioned, I am an analyst at the Vancouver Coastal East office. So that covers Tri-Cities, Burnaby, and Richmond. I was an eligibility facilitator, but it was mostly in the South Fraser region. So that encompassed Surrey Delta, Chilliwack, Abbotsford, Langley. So I do have 3 years of eligibility experience, and I wanted to share this information with you so that you're more informed when your child is transitioning to adult services. What does that look like? What does the eligibility process for CLBC look like? And how you can go about starting that process. Yeah, so next slide, please. So the topics that we're going to be covering is, first of all, who is CLBC? Community Living BC, and the roles that we have at CLBC, and then we'll move on to the eligibility criteria. So what kind of criteria are we looking for, and what is the documentation that we're looking for? Next slide, please. So who is CLBC? CLBC works with individuals, families, service providers, community, and government to create communities of belonging and lives with connection. We originated from a grassroots movement that was led by families and self-advocates who wanted a government-funded organization to focus on their unique needs. CLBC responds to lifelong needs and goals of individuals and families by recognizing their abilities and contributions, sharing leadership with communities, and funding individual choice. Next slide, please. One of the roles that you will hear a lot is the role of a facilitator. So the role of the facilitator is the first primary contact for individuals and families. When a person is deemed eligible, you will be contacted by a facilitator. When you're in the eligibility process, however, you will be reached by an eligibility facilitator. So there's two differences. An eligibility facilitator is the one that strictly deals with eligibility, and a local facilitator will be the one that moves forward with you in the planning. So at the age of 16, a referral can be made to CLBC and a file will be opened. That's when we typically start the eligibility process at the age of 16. When you call the office, your local office, you will be asked by the admin whether you're a parent, and they'll ask you some questions about your child's diagnosis, if you have it, ask you if there's any documentation. So basically, the legal guardian is the one we typically talk to, and we, as I mentioned, do an intake. If your family is connected to a child and youth supports need worker, a CYSN, they like to call it, the CYSN can also make a referral to CLBC. That's just something that you might want to talk to your CYSN about. So an eligibility facilitator will work to determine whether or not your child is eligible for your CLBC supports. Please note that this process does take a bit of time depending on what sort of documentation is provided to us. If an individual is deemed eligible for CLBC, the local facilitator will be assigned afterwards, and we start the planning process around 17 and a half. We do the planning process with the child, the family, and other supports involved, as I mentioned, the CYSN, and even the school. So once the planning starts, as I mentioned before, the local facilitator would be the one that you would want to connect with on a regular basis. We offer welcome workshops. So sometimes when a person is deemed eligible, the family does want to engage in welcome workshops in a group setting. We also offer the welcome workshops on a one-to-one setting if the family isn't open to that, if they're feeling a little bit uncomfortable. But basically the welcome workshops are open to everyone, and we provide them on a monthly basis. So what you'll notice is that there's 4 welcome workshops that we offer. The first is getting started. The second is community connections. The third is planning options. And the fourth is called the real deal. Because of COVID, we were offering these virtually, but now because of the COVID restrictions being removed, we're offering these back in person. However, we like to provide both because some families can take the time off or after work to come to these in-person welcome workshops, but some families do like to have the option of going in virtually in the comfort of their own home. So for CLBC services, they start at 19 years old. So they are lifelong. Once a person is eligible, that means that they're eligible for life. Sometimes people don't want to necessarily engage in our services at 19, which is totally fine. We have facilitators open and willing to support the individual whenever they want to engage. Next slide, please. The other role that you might hear or might come across is the role of an analyst. So typically, analysts support individuals when they're connected to service. So they are the primary contact for service providers or for agencies. The responsibility of the analyst is the contracting piece. They also monitor service quality, making sure that the funding that is given to the agency is used appropriately. It is used to meet the goals of the individuals. We as in myself, as an analyst, we also ensure that there's safeguarding in place. So making sure that the individual is protected in some way. If there's any concerns of the individual's well-being, we are there to support the agency and the family and individual to make sure that there's safeguards, protections in place to make sure that they are doing well. And if they're not, how can we support them to have a good quality of life? And then we also respond to crisis situations. We work with the families, the service providers, agencies, and the individuals to respond to any crisis that might come up. Next slide, please. So who is eligible? I want to give you guys a broad understanding of what we're looking for in respect to eligibility. Criteria is defined by the Community Living Authority Act, and we follow that legislation. We have 2 streams of eligibility and service. The first stream is the developmental disability stream. The second is the personalized supports initiative stream, which is PSI for short. I will also talk about that later on. But first, I want to focus on the developmental disability stream because that is typically the first thing that we look at before we move on to the PSI stream. So the criteria defined under the Community Living Authority Act is for 2 distinct groups. The first being adult with developmental disabilities that began before the age of 18, or adults with a diagnosis of FASD, fetal alcohol spectrum disorder, and or autism spectrum disorder, ASD, in addition to significant limitations in adaptive functioning. So people who don't meet developmental disability eligibility criteria, as I mentioned, are going to be considered eligible for PSI stream. What we're looking for in a developmental disability diagnosis is 1, the diagnosis of intellectual disability, so meeting the DSM-5 criteria of intellectual disability, which includes an impaired intellectual functioning, so an IQ of 70 or below, and impaired adaptive functioning, and the age of onset before 18. Just next slide, please. So what are we looking for in respect to documentation for consideration of the developmental disability stream? We're looking for an assessment that was completed by a registered BC psychologist or a certified school psychologist. So typically, we'll find this documentation in a psychological assessment, as I mentioned before, by a registered psychologist, or in a psycho-ed assessment, which is done during the time that a person is in high school. And sometimes we even look at psychoeducational assessments that were done in elementary school as well. But again, we are looking for the diagnosis of intellectual disability and the limitations of adaptive functioning, in addition to the age of onset before the age of 18 years old. All this is diagnosed before 18. Next slide, please. Thank you. So you'll find that sometimes a practitioner will share this with you. It's the CLBC eligibility form. It's our assessor report. These forms are necessary to confirm whether a person is eligible or not for the developmental disability stream and or for the personalized supports initiative stream. Next slide, please. Thank you. So the CLBC eligibility form review is typically done when the original assessor is not able to complete the eligibility assessor form. We ask an assessor to review the documentation, to review the psycho-ed, and we get them to fill out the review form portion. Next slide, please. So as I had mentioned when I was talking about the developmental disability stream, if a person is not eligible for our developmental disability stream, we look at whether they're eligible for our PSI stream. So the criteria is three-pronged. CLBC requires a confirmation that a person is not eligible for our developmental disability stream, but that they have significant limitations in adaptive functioning. So this is shown by a person having a combined score of all their adaptive skill areas that is at least 3 standard deviations below the mean, or 1 or 3 specific adaptive functioning measure tools done by the qualifying practitioner. In addition to having significant limitations in their adaptive functioning, we are looking for an assessment that diagnoses the individual with FASD, fetal alcohol spectrum disorder, and or autism spectrum disorder, which is also known as pervasive developmental disorder. Usually we like to have the original assessment that diagnoses the person with FASD and ASD. So just to keep that in mind, that if the person is eligible for our PSI stream, we do need that original assessment diagnosing them with ASD or FASD. Next slide, please. And just for your reference, this is the form that we get filled out by a practitioner, just to confirm that they have the diagnosis of autism and FASD. Yeah, just so that you guys can see the documentation and the form that we would get filled out. And that's it. Questions?
Excellent. Thanks, Michelle. And as I say, we'll open it up to our panel of questions a little later. I did have one, I actually, just before we move on, one of the things you talk about was, people can begin this process at 16. Sometimes choose not to,
Mhm.
particularly because they may feel like they don't need services. And as you said, they don't have to start taking these services at any point. It's really always by choice.
Mhm.
Is there a reason that they possibly should do it earlier than later?
Yeah, I mean, there's always benefits to start the process earlier than 19, just because the documentation is updated. Um, I would always recommend like starting the process at 16. So by the time they turn 19, you know that they're eligible for services. So if they say, I don't want services at 19 years old and they're eligible, then they can always come back and then we're not having to do the eligibility process. But that doesn't mean that we don't get people who are beyond the age of 19 coming to us and asking us if they're eligible. I've had many adults come to us and say, hey, like, I might be eligible, I might be not. But then that means that there's lots of documentation gathering that has to happen. And when that happens, sometimes the person doesn't have the support network to support them in that. I find that that can be challenging, gathering all that documentation. And then sifting through the records. And, you know, like if, for example, their assessments weren't conclusive, then we might have to reassess them, and that would be done through one of our contracted psychologists. So it is more of a lengthy process if a person does it beyond the age of 19, but it's not unheard of. Like we always have adults coming to us and saying, hey, I might be eligible. I have this documentation. Is it worth exploring? And of course, we always do that intake and we always look at the documentation to see if they can be eligible, if the documentation is there. But again, if they're not able to gather that documentation, it might require the eligibility facilitators to work with them to gather that necessary documents, and that can take some time, especially as I mentioned before, they don't have that support network or they don't have any documentation. That has also come up too. They might not even have anything that's of record. So then we have to go sift through more documents such as doctor records, any sort of report cards that they might have that might give us an indication that they did struggle in school. And then if that's the case, then we would want to gather as much evidence as we can and submit it to to see if we can get them a updated cognitive and adaptive assessment.
Right. And anecdotally, I guess we've heard that, we're at that place where we now have some folks with developmental disabilities
Mm-hmm.
we're at an age where their parents who've been their primary sort of their key support and providers who've lived with their parents all their lives
Mm-hmm.
are either unable to care for them or unfortunately passing away and
Yeah.
finding that they need external supports, and then they have to go through that lengthy process essentially by themselves. And
Mm-hmm.
challenging. Yeah.
Yeah, I mean, you know, you'd mentioned the anecdotal evidence. Like, I think when I was in the eligibility process, having anecdotal evidence from family members, from people who, knew the individual when they were younger during the developmental period, I mean, that's very important. Especially, I noticed that when we're supporting people who are Indigenous, a lot of the documentation can be missing. So we do really heavily also rely on that anecdotal evidence. So we don't discount that. If a person is coming to us with very little documentation, we do gather that anecdotal evidence and we will bring that to the contracted psychologist as evidence to support their diagnosis. And the psychologist will review that as well.
But it would seem particularly worthwhile to ensure that you get a diagnosis at that early age and
Mhm.
valuable in the process.
Yeah, but as you mentioned, like there's some folks who haven't got a diagnosis. They were supported by their parents or the school. I had one adult who um, was just pushed along. He was pushed along through the school system and no diagnosis was given to him, but the parents knew he struggled and we were able to work towards getting him assessed. And through report cards and notes from the school, it was very apparent that he did struggle quite a bit and we were able to get him an assessment and we were able to get him eligible for service. So there are those unique cases, but we do handle a lot of unique cases on very frequently. So there is no harm in coming to us and just exploring if eligibility is a possibility.
Great. And we'll come back to this. Thank you. And we'll come back to this conversation. I'd like to hear more around fear of diagnosis, perhaps from
Yeah.
Dr. Friedlander and also from Nicole, and I'm sure Rachel as well. So we'll have a good conversation around that. Rachel Godden is with us, and then this is great. This is a great little segue. Rachel comes to us both in her role with Bocce, but she also has lived experience. Rachel has a child, a neurodiverse child, who's now 40 and living a fulsome life. But I think that I'll leave it to Rachel to tell a little bit more about that story and just her experience being a parent in that situation. Rachel, I'll turn it over to you.
Yes, hello, welcome. Yes, so I'm a parent of a 40-year-old man, and I work also for Burnaby Association for Community Inclusion. So once the individual has gone to Community Living BC and has a facilitator and is working out goals, plans, ideas for what they want to do as an adult, they often receive funding for, let's say, funding for a day program or funding for an outreach worker. And so that funding that they'll receive for a service from Community Living BC, they then will take to a service provider. So Burnaby Association for Community Inclusion is just one of many, many service providers in British Columbia, and one of several who are serving families and individuals in the Burnaby area. So we offer we're one of the larger service providers in the province, and we offer a wide variety of services. We have infant development and daycares, youth camps in the summer. But for adults, we have day program, outreach, and then also services for people where they live. Which prior were called residential services. We're now moving away from that term, so services where people live. And so, as one part of that big organization, my role is in family support. So are people hearing me? Yes, good, okay. So my role is in family support. So we're a little small part of Bocce. We have a parent support network, parent support group for Chinese families, and some various other services. So I don't know if the web page still there, Manny, do you see can you put up the slide? Yeah. So yes, so here this is sort of I've made a page of the support groups with people with a disability. And I think, as one of the big things that, comes up for all families, but, especially for practitioners, is serving families with language needs or who don't speak English as a first language. And, there's a lot of complexity. I mean, we see in Michelle's presentation, although she presented very clearly, the information is complex and a lot for families to absorb. So for families, having a place to go where they can, get support in their own language, is vitally important. So I've shared these links here with, what services there are out there for people who are looking for supports in other languages. As well, there's tremendous amount of supports within within British Columbia for all kinds of things, in terms of, doing wills and estates, in terms of making sure that you're accessing all sorts of other services that are available. So our Bocce family website, or Bocce Burnaby Association for Community Inclusion, on our family website, there's a comprehensive list of resources that are available for families and places to go for information about things like, one thing that, as you're coming into Community Living BC, people will be asked to do is, once their loved one turns 19, to make a representation agreement. So that means that the individual who's now an adult is choosing a representative to speak for them. So that's, one of the many, many things you must do as your child's moving to adult services. And there's places and organizations that help with that. So our website has a ton of information on all that stuff, and it's a great place for families to go. So that's of our family services department, is to link people with other resources and supports to help them with the various things they have to do to support their child, or even just looking for arts and recreation opportunities. Often when people are coming out of school, schools provided a huge amount of structure in their lives, and suddenly there isn't that structure, and it can be a time for a time of where people are quite vulnerable to mental health concerns, feeling isolated, becoming more withdrawn, becoming computer addiction. I don't know if that's the correct term, but to overuse of computers. So it's a time where families really are looking for a lot of supports and resources in terms of building that adult life, and CLBC is there to help do it, but they're not a one-stop stop. The facilitators have a lot of families they're working with, so there's all kinds of other supports and resources that families can connect with to help them with that process. And I'll stop there, and people can ask questions as they need.
Yeah, and as I say, I think we'll have a discussion in a little bit. Or Rachel, maybe just before we move on to our panel discussion, can you talk a little bit just from your own point of view, what was challenging for you as you moved as you moved down this path with your child?
Yeah, I mean, my son's 40, so it's a long time since we were going through the process of him being diagnosed. He has a rare disability, and he's significantly impacted. So he has physical and intellectual disabilities. So we were realizing pretty early on, by the time he was 3 months old, that his development wasn't typical. And and the process of having him assessed and diagnosed, it's very, very challenging time for families. I think there's a lot of fears, and a lot of long-term fears. How's my child going to manage as an adult, and it can be very overwhelming. So I think there's a lot of families are dealing with a lot emotionally, as well as a lot in terms of navigating all the systems. So it can be very challenging. And I think speaking to people who work with families and work with professionals, there's a real need to meet families where they're at, and to be patient with families, and understand that if families don't seem cooperative, it can be because there's really a lot going on with the family, and feeling like professionals are compassionate. I loved what I was hearing from Michelle about come to us, we'll work with you, we're here, we're listening. I mean, that for a family to feel like that, rather than feeling like, well, here's all these hoops and here's all this forms you got to fill out, now go away. That's tough, because there's a lot we're dealing with as parents. It's hard. I mean, my son's 40. I'm still every and he doesn't live with me any longer, and still every week there's many things I'm dealing with in terms of building that wonderful life for him.
You're still taking that key role. Yeah, absolutely.
Yeah, absolutely. Yeah.
Well, that's great. Well, I mean, I have a good list of questions, and I think there are more coming in the Q&A. So that's wonderful. I do want to take a minute to introduce Nicole. I mentioned briefly that she's a district vice principal of inclusive education for the Burnaby School District. Essentially, she works with the schools, and she works with the students in the schools to ensure that the folks with a broad range of abilities have the best level of inclusion and access to the services. And just before we start our overall panel discussion, Nicole, I know that it's been a busy couple of weeks for you, and I don't want to put you on the spot, but I just wonder, from your perspective, from the schools, what are the challenges that you see for neurodiverse kids, but B, for parents who are sort of navigating, trying to figure out where their kid is in the world?
Yeah, no, that's a good question. Hello, everyone. I think like startup of any process, it's ensuring that communication systems are set up so that families and teachers know who to turn to and what's in place to collaborate to ensure that the child is set up for success, the student is set up for success. Because there's lots of good planning that goes on to support students, but it takes time, and there's logistics that need to be kind of set in place. So one thing that we always we really value in Burnaby is articulation processes, we call them, and they're processes to ensure that transitions happen smoothly and that the team is kind of speaking the same language. So that would be one of the main ones, Jeff.
Yeah, thank you. That's great. I want to start with our panel discussion with a little bit. One of the things we've been talking about is diagnosis, and a number of the questions that folks have are around how to get that diagnosis in a timely way. And Michelle, you pointed to it, but I think that some of the questions are around if I don't have a family doctor, what do I do? How do I get this if I don't have a pediatrician, if I don't have a family doctor? How do I get this if I'm a newcomer and I'm not really linked to the health system? What's the point I can do this in? Would anybody like to speak to that?
I can start with a school perspective, but if somebody would like to,
oh, go ahead, Nicole, and we'll
and maybe others that might cue you to jump in. So if you suspect that your child, a child has atypical behavior, how do we start? The starting point in a school system is always the classroom teacher to relay any concerns or start conversations about what you're noticing as a parent, and to communicate that. And the idea is to open up a dialogue around what are you seeing at school. And from there, a classroom teacher has access to what we call learning support teachers, inclusive type teachers, who are always available to have conversations around students and what they're seeing. They see a suspect area of needs, how to support students within the classroom. And just quickly, Burnaby operates using a multi-tiered system of supports. And so for those of you who might know response to intervention, that's a version of a multi-tiered system of support. So we start at a universal level, providing supports that are good for everyone. And then we slowly increased based on collaboration, data, observations, whether or not which interventions to implement, and where to go from there. What are our next steps? And so I think the first step when we don't have doctors is to gather that information and data to help better understand a student. What are their strengths? What are they good at? What are they thriving at within the school? And where are their areas of need? And has the classroom teacher started at that base level to implement some strategies or interventions, maybe in collaboration with others or based on their experience, that might help the student. From there, we kind of analyze the data and kind of look at what we're seeing. If we're making headway, fantastic, our interventions are working. If not, then we move up to tier 2, tier 3. And some people might move up, some teams might move up quite quickly. And so that data, this conversation that I'm talking about, is often shared. Schools can share letters with families to take to doctors, whether if they don't have doctors, I can't speak thoroughly, so somebody else might be better equipped, but they might go to start at a clinic to get a referral. They might start at different places. I see Michelle nodding, so she might be able to speak to that a little bit better, but I know there's lots of avenues. And so that's kind of a starting point for parents at the school level.
And I'm going to ask Michelle about this, and actually also Dr. Friedlander. But I guess a question I have, you talked about coming to the teacher. Is there a stigma that parents need to overcome? Is that something that's an issue sometimes?
You want me to answer that? Absolutely. As Rachel was talking about, it's and I don't want, it's a lot for that families are going through. It is a journey and a process, and people have different beliefs and ideas around labels. And we see that particularly a lot here, around different cultural views, around different families not wanting to pursue anything. And so, yeah, we do see a stigma around it. And our approach as a school district is talking about the differences. Labels don't give us all the information that we need in the world. They often serve a purpose in our province around funding. They can direct us for resources, and they're very useful in a lot of ways, but we really stress that we always want to meet children where they are, and that we want to address their areas of need. So the label for a school system for families to know is that that is not important to us. That does not drive how we view children. It does not drive our interventions. What drives our interventions is the area of need, because a student with autism, two students with autism can be completely different, right? And require different types of supports. So there is a bit of a stigma. So we really work hard with families to have a really supportive conversation around making them feel comfortable and that we're here to meet the needs of their son or daughter.
Great. Thank you. Michelle, and I'll go to you on it, just in terms of navigating and finding the ability to get the diagnosis. Do you have any sort of guidance or advice for folks particularly if they don't have a primary care provider for their child?
Yeah, I think that Nicole touched on a really important topic of collaboration with the school, because a majority of the assessments that I have seen have been through the school, just addressing, the concerns that the parents might have, and then also the teachers themselves. I've noticed have been really great and proactive and in addressing, like, okay, there is a child in my classroom who I think I have a feeling is not is having trouble engaging. They just notice like some behaviors, and they say, okay, well, maybe it would be important for us to see, if we can get them a psychoed or some form of assessment that can either diagnose them, so that the family has an understanding of, okay, like, this is what we're working with. How can we go on to support our child in the classroom setting? Does it give them any additional support in that classroom? But I have also had families who come to me and say, like, they had an assessment way back when the person was in elementary school, but nothing has happened in high school. I would help the family either reach out to the school district, and then I would say, because we have a network of school psychologists that we regularly get in touch with, we meet with them every quarter, and we say, okay, like, from your list of who you have, of the students who has been assessed, who hasn't been assessed, is there this name on the list? Because we were told by the parent, they've came forward and said that this person hasn't been assessed since they were in elementary school. Is it possible to get them assessed? We work with the school psychologist to see if that's a possibility. Sometimes if a parent is unable to pay for a private assessment just because it is quite expensive, we have the ability, if we have enough documentation, to make that referral, whether it's to Able Clinic, whether it's to a Sante Center, whether it's to our contracted psychologist, to get that assessment done. Of course, we need to have ample evidence that supports that trajectory of getting an assessment, but we would always work with the family and the individual to make sure that if we find, there is a need for the assessment, we would pay for it. We would pay for that out of our own budget to make sure that if a person does need that assessment, and if they would meet our criteria, we would get that done for them.
Great, thank you. And but I think that there's time and money. It's always there's one and then there's the other, and it seems like it's still a challenge of time, particularly if you don't have an easy access in. Dr. Friedlander, would you have sort of a perspective from your practice on when folks come and they need or want an assessment, and what or by that time they're coming to you?
Yeah, thank you. I think kind of diagnostic labels I think have a mixed review. Most people kind of think they're useful, but as Nicole pointed out, you can have two kids with autism and they're completely different. So diagnostic labels have limitations. I think everyone seems to feel, I think everyone who thinks about it thinks that a needs-based funding stream and service would be better than a diagnosis-based one, but nobody's come up with a way to do it yet. So we kind of stuck with the diagnosis based access to get extra services. And you know, within, like for example, within the school system, if you have autism, even if you've got the mildest autism in the world, you actually get far more funding than if you have severe ADHD. I mean, the school may be able to develop something for one particular child, but there's no doubt that certain diagnoses automatically get much more support than others. You know, in my practice, as I said, the two disorders I deal mostly with are autism and intellectual disability, the two neurodevelopmental syndromes. So autism is often diagnosed quite young nowadays. And I tend to see kids over the age of 6. So most of the kids I see, they may have an autism diagnosis, they may not, but they come to see me with their behavior problems. And as I pointed out, as a rule, autism is not normally the biggest driver of the behavioral challenges, not in itself. In terms of intellectual disability, because psychological services at the schools are really quite limited, my experience is that very few kids get psychoeducational testing through the school system when they're younger. And often the first psychoeducational test they get is when they're 16 or 17, and someone is thinking, well, we better get see if they're eligible for CLBC services.
Thank you. Actually, Nicole, there's a question here specifically around this, and this is a question that comes, and I have no background knowledge of it. They asked about what's the difference between diagnosis and designation in the school system.
Yeah, that's a great question. So a diagnosis is done by the appropriate professional, which can include a doctor, psychiatrist, different types of doctors like psychiatrist, or a school psychologist is also falls under these professionals. And so these professionals determine if a student meets criteria, a person meets criteria for a particular disorder. For example, a pediatrician might diagnose ADHD, a school psychologist might diagnose a learning disability. After this diagnosis is determined by meeting the criteria, medical reports are created, shared with the families, who then share with the school. So the diagnosis is done by a medical professional, whereas a designation is something that happens at the school level in accordance with adhering to ministry criteria. So schools have to follow ministry criteria for these designations, and they're labeled in letters. For example, we're talking about autism a lot in our examples today. Autism is determined by the letter G, and it has specific criteria by the ministry to determine whether or not that student does meet that diagnosis of autism. So in the school system, specific school professionals are responsible for signing off, we say, on a designation. And what we mean by that is this school professional, for example, I'll use the school psychologist, suspects that somebody has autism. We look at the ministry criteria, which you can find online, and they review a student's file, do observations, and determine whether or not, with the school team as well as a part of this conversation, and review of the doctor's medical reports to see if they meet the criteria. Once they do that, each school district will have a system where they document that and agree that the student does have that diagnosis, and therefore will get the designation. So that's kind of how that looks. And it's done by different categories. And so we have school psychologists who sign off on things. We have teachers of deaf and hard of hearing, or teachers who support vision impaired, those who are vision impaired. And then we have district learning support teachers too, who might work in combination with counselors to sign off on students maybe with mental health challenges. And a little note about community or outside advocation for designations. Occasionally at schools, we receive a letter from medical professionals, doctors and psychiatrists, stating that a child meets criteria for an autism a G designation. And we appreciate all the information that medical professionals provide to us. But the decision to provide a designation is not a medical one, but an educational one based upon the ministry's criteria and the student's ability to function successfully in an educational setting. Oftentimes, the doctors that we have collaborated with in Burnaby, they know their stuff. And so they are right on. But it is ultimately the school, the districts are responsible for meeting the criteria, so that we report back to the ministry. So we have to feel confident in having people look at the medical reports and all of the information as well.
I mean, so it's, I mean, to some degree, Dr. Friedlander alluded to it. I mean, you're in the place of trying to take all the supports you have and providing needs-based and providing it based on need rather than on diagnosis or designation.
Yeah. And so would you like me to speak to that a little bit?
For a minute, yeah, that'd be great.
Yeah, well, and Dr. Freelander, I agree with you completely, and I saw some heads nodding here, and we talk about this all the time, this needs-based approach, right? And so what guides our practice, just so to be transparent with everybody, is when we support students and collaborate with families with our main goal is to think about how can we foster student independence to help these individuals have, by the time they lead us in grade 12, maybe 13, have a quality of life set up with some skills that will empower them to be an active member in the community and find joy after they leave us. And so that is our goal as we move through school in terms of looking at how we support students. But supports can look like many things. There's kind of a stereotype that a support is an education assistant. It's not always the case. Supports look like counseling. They look like learning support services teacher having in-class, we call it in-class support, where they're co-teaching or engaging in small group tier 2, tier 3 interventions on social skills or something like this. It might be some out-of-class support to work on some different types of skills that are related to an individual education plan. Supports can also look like other things as well. I just wanted to point out that it's not always an education assistant, and we're always keeping in our mind, how do we foster independence and set these students up so that we can fade prompts, so set them up for success. And we also collaborate a lot with the families and talk about what strategies are working at home and how can we implement those in the school and vice versa, and work with extended team members as well. Yeah.
I'm going to come back to you with how you link to the community. And I'm just trying to say this now so I remember and you remember how you link to community agencies as well. But I would like, one of the things that you brought up, and Dr. Friedlander, you brought it up as well, is the overlap of diagnoses. And there's a good question here about, how do I know that the mental health issues are about the disability, or not the neurodiversity, and not the hormones? It was sort of, and I think that, I don't know, Dr. Friedlander, if you wanted to talk to that.
Great question.
Yeah.
So I mean, there's sort of different sort of times in life or in development when kids are more likely to have behavioral challenges. And certainly puberty is a big one. And the number of life things going on at the same time. These kids are going to high school. They're entering a developmental stage. They're getting bigger and stronger and more and developing, sexual characteristics. And the hormones are pumping, as many of us recall, because we've been there. And so when the kids have behavioral problems, I can tell you every single parent assumes that it's hormones. And they may be right. It may be that the kids had behavioral problems for a long time, and now they're bigger and stronger. So that's one possibility. The other is, girls can have irritability or dysphoria around their period. So that's one other possibility. Another is that there is that sort of more classic mental illnesses like major depression and bipolar tend to have their onset for the first time often after puberty. And so that's one of the things that I'm always looking for. Is this the onset of a mood disorder? Because that's really important to note that, oh, it's not just ADHD anymore. The kid's now also bipolar. That's important to know.
Yeah. So, and following up on that, then what are the supports that this is a question that someone's asked, and it's a really good one. I think that it's always challenging to find supports for mental health for youth and children overall. I think that from my knowledge, and it's doubly, and maybe that's an understatement, challenging to find in the community supports for mental health for the neurodiverse kids. Is that true?
Yes.
So what can we get? I mean, and Michelle is nodding as well, and Nicole and Rachel. What I'm really sorry. I'm really interested in what advice we can give people to find supports in the community. What are the avenues that they can? I mean, certainly through the physician's office. I'll start with Dr. Friedlander, and I'll go to Rachel.
I think Rachel wanted to say something, so I'm happy to wait.
I was just going to say there are a lot of different family support services out there, some through Children's Hospital, which I'm sure Robin could speak to. There's a program called Family Smart that has monthly parent support group meetings. So on our website, there's a whole list, but there is a lot out there. And I think, often parent to parent information sharing is an amazing way to find ideas and resources and places to go to get more support. So, any family, I would suggest connecting with other families.
That's great. And I know that for Michelle, it's like once they hit that age, then there's a door that opens, and that's great. It's just that those younger folks are. Go ahead, Dr. Friedland.
Oh, I was going to say, I agree with Rachel that often these families feel isolated. Even if the kid's got autism, and there are sort of lots of services nowadays for kids with autism and programs, but these families may say, my kid's very different to all those kids who are going to that Canucks Autism Network program. The other parents, they don't even understand what I'm dealing with. So, and if that's the case, I think family-to-family support with a parent who has similar challenges is really helpful. There's actually another organization which I often refer to, which Rach didn't mention, called the Family Support Institute of BC. I find them terrific. They really offer a wonderful service for families in terms of this family-to-family support, and they've got information on their website, and they do a lot of good work.
Just I do want to, there was a question in the chat, and I'll just bring it forward. All of the resources that you hear about today, you'll be able to, I think we tend to send out, if we can, a report to the folks who attend, but I'm not going to promise that. But if not, they'll all be available on the website, and you will have the link to that website. So not only the slide decks that you've seen, but the other resources that we're talking about. And also, we're giving you avenues to find more of those supports. And Nicole, I want to bring this question back to you and tie it back to the one that I was thinking about earlier. How does the school link out to the supports beyond the school, or does it?
Well, one of those ways is that a value and theme, and I don't want to underestimate this, is collaboration. And when we in Burnaby say the word team, I want to be really clear about who that involves. It involves the student's voice. It involves the family, any extended team members they may have, as well as the school team. So we offer opportunities to meet all the time if the participants are willing, and share strategies and converse around what's going on. So that's one way that we go about kind of connecting and collaborating and looking at resources. In other ways, we've also each year, we review who's in our district and what the students' needs are. And so we have, I enjoyed, Dr. Freelander, your research that you brought up, that slide you brought up, because we are seeing the impacts of the comorbidity of mental health challenges on students with autism and other developmental disabilities. As a result, most recently, Burnaby created a position that is titled a mental health liaison. And so this person connects these people, we have 3 now, connect, and I've worked with them quite closely in the last couple of years. They connect to community resources and the family, and then also connect to the school or the district, because there sometimes are challenges there. So that's another way, they're another, and so on a larger scale, we have all of these teams, and then as an administrator of learning support services, I bring everybody together to share these messages as much as possible. So Rachel, I appreciate you referencing your website as well. I want to share that with my teams so that they're aware of supports and services beyond maybe what they already know.
Yeah, that's great. I mean, I think it's, I'm just going to take a little paid, moment to advertise sort of what the way we look at this within Burnaby, both in the primary care networks and beyond, is the more we can connect with one another around patients and people, and share and share what we know and share our supports, the better the supports will be, and the more people feel supported and connected. So that's a great place. Michelle, go ahead.
Yeah, I just wanted to mention, like, I really appreciate this discussion of mental health and transitioning youth coming up, because I think, like when you're going through that transition, you're feeling so many things and you're like, okay, well, nothing, like for me, like being a teenager and growing up, it's like I'm neurotypical, and I would think, like, oh, nothing bad happened to me, but I still feel this way. So why do I feel this way? And it's really about like teasing out, like what is going on for that person. And I think a big sort of organization that a lot of my colleagues have mentioned was Foundry, because Foundry specifically targets, those youth, and it goes up to the age of 24 or 25, I believe. And because of the population we support, having a designation, having a diagnosis, and dealing with mental health and even substance use. Substance use has been huge. And I've noticed a lot more youth coming to us with existing substance use concerns. We are trying to pair with Foundry to really understand how we can support our individuals who need mental health supports, in addition to perhaps recovery or detox, that kind of thing. Because what we're finding is that the regular route of supports when it comes to substance use isn't always accessible to our individuals. I've had a few number of folks going to Redfish, and they're finding success with Redfish, the Redfish Recovery Center. But yeah, we're trying to be more mindful that individuals who are CLBC eligible, who are going through that process, who are struggling with mental health and substance use, might need a different approach. We might need to tailor the program specifically for them. And it's just to accommodate, like the learning styles that they have. And that is still very much in like the primary beginning stages. So it's something that we're trying to focus more on. And then if a person is CLBC eligible, there is DDMHS developmental, if they have the developmental designation, they can access DDMHS. And then there's also CBI and Possibilities that we contract with. They provide behavioral support to individuals and families. So if there are behavioral challenges that do come up that require a behavioral consultant to be involved, that's when we would make the referral to CBI and Possibilities for that.
And I'm really glad you brought that up around substance use, and I'd like to hear some other thoughts around that. I think that I kind of go back to that as you started out, Dr. Friedlander, this idea that there are multiple pieces. It's never this. You have to look at whole person, and some of these pieces, one feeds the other. Which and so I wonder how that. Can you speak to the issue of substance use and how that complicates things both for the patient and for the parent?
You're asking me, Robert?
Yeah.
Okay. So I can just tell you that unfortunately, substance use disorders are common across the general population. In my experience, however, it's quite rare. And I think that's because the majority of youth that I see just don't have the independence to get out there and get into trouble with substances, which is a blessing in disguise. So it's not my area of expertise.
And that's fair. Nicole, is this something that you see in the schools?
Similar to Dr. Friedman, not so much that I've had a lot of experience as well. No.
Interesting. Thank you. I do. The reason, sort of the knowledge that I bring to this is, we're working on another initiative around guns and gang violence in Burnaby, and we're hearing, we've heard that there are neurodiverse kids who are being brought into that, and that's sort of also their avenue to drug use. One kind of
yeah. I mean, I think it is real. What Michelle is describing, Michelle's CLBC is basically a service for youth and adults. So for adults, not youth, for adults with intellectual disability and autism with very low functioning. But these are very vulnerable individuals. And so if your IQ is sort of like 60, you kind of maybe masking a lot of your challenges. You want to fit in with the cool kids. These are very vulnerable individuals, and I could see how they could easily want to hang out with the cool crowd and develop a substance use disorder.
Yeah, it's definitely what we hear. And I think that Michelle, it's great to hear that CLBC is thinking about this and developing some specific supports for it, because I do just know that, again, it's anecdotal, but that we hear that parents are they don't know where to turn because the avenues that are there are just not as accessible. Foundry, I do want to make a little plug for Foundry. I agree that Foundry does some wonderful work, and that in case folks don't know, many of the services that Foundry offers are available online and to everyone, even if you don't have a Foundry. And I will also say that we are working hard to try to land a Foundry in Burnaby, so we're certainly hoping that will come about. That's on the plan. Robin, did you have something else?
Oh yeah, I just wanted to say that just in terms of options for help, there's child and youth mental health. It's often kind of unclear where child and youth mental health, what they do and what Foundry does. I'm kind of often confused, but there's child and youth mental health. I can tell you it sounds a bit weird, but if the kid's too complex, they'll say, no, this is too difficult and complex for us. We don't do that, which is not ideal, but it's a reality. There is our neuropsychiatry clinic at BC Children's Hospital, and we see a lot of very challenging children and youth, but we're a tertiary service. But still, we're often the only game in the province, and we will see these kids and sometimes follow them. And then because I was saying there's such a problem getting access to child psychiatry, there's the Compass mental health program, which is for physicians to call in to discuss their patients who they need some help with.
It's interesting because you talk about physicians. We know that family doctors in Burnaby, well, we know probably all, but we know very more intimately, family doctors in Burnaby are saying more and more the issues that they're dealing with are around mental health. And their role as a family doctor is really, it's really as more as a navigator than as a provider of service around mental health, but they need more supports. And in fact, there are, through the primary care network, there are actually dedicated youth mental health services available primarily through your family doctor, but there are other avenues as well. So we'll put those resources in the resource guide that we provide as well. These are new services that we can that have come to Burnaby through the primary care network. There are additional services, so it's great that that the doctors have identified it, and B, we've been able to land some of those resources. And certainly with all of the PCN resources, we've worked really hard, largely through the sort of the collaboration and conversation with some of the groups we work with to ensure that they're broadly accessible across the neurodiverse population and beyond. So those are out there, that's for sure. And we're moving to time. There's a couple things. One of them was around, and I guess I framed this one in my world, that we talk about social determinants. You know, what are the impact of where people live, whether it's in the economic condition, or whether they live in some sort of care facility, whether they live in a foster situation. What are the impacts for those folks in terms of accessing care, and and being able to, or even Nicole, I guess from my curiosity is, what do you do when, from a school's perspective, you've identified some conversations that need to be had, but that key provider is not necessarily that key responsible person is not necessarily a parent, or even a particular person? Is that more challenging?
To help support the student? Sorry, can you say that
so
again?
Perhaps if they were living in a group home, or if they were living in a foster home, those type of situations.
Not so much if they have guardianship, if the kind of legalities are worked out. Oftentimes what happens in those situations, a social worker is tied to this student, and so they have the ability to sign off on decision making that impacts the student supports. So to date, it's been quite collaborative in that respect, and we haven't hit too many bumps. Yeah,
that's great to hear. And Michelle, along the same lines, do you find that as long as that's I guess the question is, what happens if it's not well defined? That becomes a challenge.
Yeah, as Nicole had said, like typically we would get referrals from the guardianship social worker, and the guardianship social worker is the main person we would talk to. It does make it more challenging if the individual is referred and they don't want us involved. Right. Then we would have to definitely discuss that. But like moving forward, if they're eligible and they're 19 and they're like, I don't really want to engage with you. But for the most part, if things are kind of all, working great and they've been connected to an MCFD guardianship social worker, then it's pretty smooth. I haven't encountered a situation where they haven't been.
Great, thank you. Rachel, I don't know if you have any input on that. Just through Bocce, I'm sure that's you work with kids who are living in all kinds of different places and situations.
We do. I mean, I'm primarily working with families. So I'm not so much the individuals, but I have worked with families who have a child who is living, who wants to be independent, and yet it's not now. And I think that's one of the most anxiety provoking of all the parents I work with. Those are the ones, who, my son, for all his challenges, he's like he has the level where he needs the care of a small child, so he's not out on the community on his own making poor choices. And for parents who have children or adult children who are making those choices, it's very, very challenging. I mean, one thing is that there is the public guardian, and there is issues around self-neglect, and where that level comes in of getting the public guardian and trustee, and CLBC is a mandatory reporter on self-neglect, and especially the situations I've seen is sometimes when the person who's CLBC designated gets into a relationship with somebody who is taking advantage of them, and estranging them from their family, and is exhibiting coercive control over them, then that can be a situation where CLBC, as the mandatory reporter, will have to get in to ensure that person's safety. So if you could comment on that, Michelle?
Yeah, I think, I've been in certain situations where we haven't necessarily determined a person eligible, but there are concerns about self-neglect, abuse, neglect, all that kind of things. And so we wouldn't necessarily be the designated responder if they're not eligible. It would be the health authority, but we work in tandem with the health authority to figure out eligibility. So I did work on a case where the person was in hospital and the health authority was involved as the primary adult guardianship investigator. And I was working with that particular social worker on getting eligibility figured out. So yeah, like if they're eligible for our services, we are definitely the designated responder when it comes to abuse and neglect. But if they're not, but we suspect eligibility, we wouldn't necessarily take the back seat. We would work with our health partners to make sure that the eligibility process is seen through.
Yeah, and I'm speaking from the perspective of a family who has a loved one who is CLBC eligible and has a lot of concerns around self-abuse and neglect. And I'm saying then in that case, the family can find community living.
Yeah, for sure.
And get them involved in looking at that, because you know, that can often be a way of bringing in some more resources and supports for that person, if you know, and including if substance use is involved.
For sure, yeah. If the person is eligible in service, then we would definitely step in. We get, you know, community reports. We get, you know, even like if the agency is noting some things and like the agency is very concerned, then we step in definitely to investigate. Sometimes it does involve more intrusive measures where we do a removal, for example, if the person is living in a home that's just not safe for them. And that would be more intrusive, but we do try to do the less intrusive response first. And then if we do need to do an emergency where things are moving very quickly and we have to remove the person or we need to implement services right away, we would do that.
Right. Well, thank you. We're coming to time, and what I'd like to do is just give. I want to offer the panelists two questions, and you can answer whichever one you prefer. These are questions that are a little more personal from a parent point of view, and there's sort of a yin yang to these questions. The first is, and as I say, take think about this for a sec. You have to just take a minute to give us a response. How do you identify the strengths of a child with a neurodiverse child? And the second is, I need help when anxiety turns to anger. Who would like to start? Identify the strengths or help with anxiety turns to anger. Go ahead, Nicole. Thank you.
That's a great question, by the way. How do we help identify the strengths? From a school-based perspective, it starts with getting to know and spending time with the student. And that is done oftentimes in classrooms through community building and kind of social emotionally led programs that create positive environments for students to kind of be in all year. On top of that, the new curriculum has some core competencies around kind of personal identity, personal social skills, as well as communication. And so teachers often every year engage in self-assessments. They get students to also self-assess on particular strengths of themselves. So the conversation starts with the student. So really listening to the student voice, and teachers have been getting really creative around how they're eliciting this information. It's really neat to see what happens. I'm not sure what individual with what background is asking that question, but in educational kind of latest research and presenters out there, individuals like Shelley Moore on their website have tons of information on class-wide activities and things like this. So oftentimes teams are collaborating around how to get that information out of kids. And then I don't know if anybody else wants to add to that, but.
That's great. No, I'd like to get everybody's input on one question or the other. Before I go to the next person, though, I will say that if you can stay around, I'm talking to the folks who are on the webinar participating, to do a quick poll at the end. We need to do some evaluation. It would be greatly appreciated. And if not, we can send it out. So just so you know. Now, back to the questions. What do I do when anxiety turns to anger, or how do I identify strengths? Go ahead, Robin.
Okay, so the strengths piece. I think it is really important to people come to me and there's so many problems, and it is important to try and actually have just a brief conversation with the parents about tell me some of the good things about your child, both for me to know and for them to be able to share some of what they're proud of, because there's so many things that they feel kind of upset and embarrassed about. And it's helpful for the kid to hear it, because often they're hearing all the problems. In terms of anxiety, yes, anxiety is one of the big causes of anger. And often these neurodiverse kids are not able to participate in traditional anxiety management therapy. There's a really good program called, I'm just putting it into, called the SPACE program, which you can look up, developed by a psychologist called Ellie Leibovitz. And what it does is a parent-based program where the parents are supported to help support their child and reduce accommodations which parents put in to stop the outbursts when the kid's anxious. And the parents say, look, you really should go to school, and the kid has a major outburst, and the parents say, okay, it's okay, we'll leave it for today. It relieves the anxiety in the short term, but the next time the kid's going to be anxious again, and you're getting another outburst. So it's a really good evidence-based program that is parent-based.
That's excellent. That's great. And you can't see what Robin posts, but we will make sure that and just for the person who asked that question specifically, www.spacetreatment.net, and we'll also make sure that those things are shared. Michelle or Rachel, would you like to go next?
I'll jump in. So, my youngest child, not my child with a disability, my youngest daughter has attention deficit disorder. And I know that if you have a child with attention deficit disorder, you can feel like you spent all day saying, no, don't do that. You're doing this. And I worked with a wonderful psychologist who said to me, he said, I want you to spend, and he said, I know it's hard, maybe only 10 minutes, as much, but have of time every day where you follow your child, whatever if they want to tell you about their video game, whatever it is, just have a period of time where you follow them and you give them your undivided attention following what they want to do. And that way they getting positive feedback from you, and you're seeing them as they are and following their passions. And it was one of the best pieces of advice I've ever been given. So I'll share that.
Oh, that's wonderful. Thank you. Yeah. And Michelle.
Yeah, it's interesting because I got your second question and I thought of it very differently than what was proposed. But I was thinking about when anxiety turns into anger in relation to the parents that I'm supporting, because I know that it's during eligibility specifically, there is a lot of anxiety. As Rachel had mentioned, there's a lot of anxiety around whether or not your child's going to be eligible. What is the future going to look like? What if they're not eligible? What does that mean? And I do get a lot of parents who become, their anxiousness becomes anger, and they might, be explosive towards me. They might call me and get upset and yell. And, I truly like to tease out, what they're really upset about. And that kind of, it does take a bit of time when you're talking to them on the phone. I do have lengthy conversations with families, and I do say, it definitely sounds like you're anxious about this process. How can I help you through this? How can I make it more manageable for you? Should we break this eligibility process into smaller steps that it seems less overwhelming? And sometimes it's a matter of really going through the eligibility determination and what that process looks like, so they can digest it and understand, and that really helps them focus their attention. So we go through the eligibility criteria, and I say, okay, this is what we're looking for, and they, hopefully I can explain it in a way that's manageable for them, that's understandable for them. And then we kind of break it down into small tasks, because I find when you're looking at the large picture of eligibility, it can be very overwhelming. So if I say, okay, let's focus on this task. Let's get this done, whether it's signing consent forms, whether it's getting documentation. I also offer myself as a way to get documentation as well. Are you having a really hard time gathering documentation? Can I make it easier? Can I get that for you? And just try to make it manageable. That's how I help the family when it comes from a place of anxiety, but it comes out as anger. And from the identifying strengths perspective, I find like when I was a facilitator, pinpointing even like the smallest of things that might be very mundane, or like something that's like something that we would take for granted. So like if a person can get a personal care routine done independently, I would be like, that's a strength. They're able to do that by themselves. That's a win. Like if they can do that, if they can manage themselves, whether it's brushing the teeth, getting their clothes on, choosing their clothes, making that choice for themselves, that is a strength. That's a win. So I really try to take the small things that people might see as small, or like very, like, oh, it's whatever, it's a task. That's pretty great. And if I can build on that, that's wonderful.
Excellent. That's sort of that same meet people where they are that Rachel
Yeah.
was talking to. Some great comments, you guys. Thank you so much. And it's a nice, great note to end on. I really want to thank the panelists. You've been wonderful. I also want to thank the folks who participated and with such great questions. And I will say, I remind you, when we sign off, there'll be a poll up. If you can stay on and do the poll, those participants, that'd be great. If not, you'll get one in your email. If you do want to see this Doc Talk, or share it with your friends, or with whomever you'd like to share it with, we'll send you the link to it. There are lots of other resources on burnabypcn.ca. You can access a whole bunch of different resources for support around health and well-being in Burnaby. So please take a look. And with that, we're a little bit over time. So I will just simply thank everybody, and we'll see you at the next Doc Talk. Take care.